that is recording.
It is.
Okay, thank you.
You're welcome.
Thank you very much. Right, Tasmin, thank you very much for coming. I just want to just talk about the settings so that we understand that you are Kate registrar, but Kate is on midterm holiday and we've arranged this so that you can take your tutorial today. And prior to this time, we've been exchanging emails. So you said you wanted dysfunctional uterine bleeding and then menopause, yes? And then I then say, can you just clarify exactly what you want? So you say just thinking more along the lines of managing menorrhagia, pain and contraception in both settings, but overall keen to learn general women's health in more details, so anything suits. So I've looked at maybe a bit of menopause, menorrhagia, and contraception, especially emergency contraception. So will that be what you meant by your email then?
Yeah.
Okay, so, all right. We have problem with this camera. The last time when we did this, the dates are not recent, so it was like 5 years ago. So I just want to say that today is 24th of October 2018 and not 2013.
Okay.
Right. Okay, so tell me, because this is the first time I'm seeing you, Kate wouldn't ask you this question because you've been working with her, so I'm seeing you for the first time. What is your preferred way of learning? Like when you have your tutorial, what is the best way you learn from your tutorial?
Usually we kind of start around a case and then we kind of talk about the different aspects of the case and then we go on to talking about kind of history, key questions, examination, management. Oh,
okay. That's fine because this topic that we are talking about today, I think it's good using guidelines, but then maybe relating theory into practice so we discuss it around case scenario, so something that you will actually come across.
Yeah, that'd be useful.
Yeah, so have you, since you started, how long have you been in summer?
I started in August.
August.
In a couple of months.
Oh, okay. So have you seen any patients with these topics that we are discussing today?
Yes, I've seen quite a few, and some of them we've discussed with. We have a kind of GP with specialist interest in women's health. Sometimes we bring it to the meeting.
Okay. Yeah. So in preparing for this tutorial, which resources did you use?
So mainly CKS is the thing that I use, but also the kind of professional reference on Patient UK.
Okay.
And then I looked at UK MEC.
Okay. Oh, great.
The Faculty of Sexual Health and things like that.
Okay. Did you look at the Royal College of Obsangani Green Top?
No, I didn't.
Okay, so that's very good. About what have you heard about Bradford VTS?
Yeah.
Did you look at that as well?
I've looked at it for my e-portfolio.
Okay.
Yeah.
So, but did you look for this topic?
No.
Okay. Because there's actually a presentation there that is really very good with good scenarios. So we may use that as a sort of a framework, but then we can actually ask questions and discuss more details because you say you to learn women's health in more details, so anything so we can use that. And then maybe do some case scenarios in emergency contraception and then discuss menopause. So if we start with the menorrhagia and then we go on, is that okay?
Yeah.
Then we then do case scenario, then we move on to maybe emergency contraception, then we come back to menopause. So if we start with menorrhagia. So when you say menorrhagia, so what do you understand by menorrhagia? What is menorrhagia? So I'm just going to bring up.
Basically heavy periods. When I looked at different websites, it said different things about quantities. So it was saying about kind of over 80 mils of blood loss.
Wow.
But I don't know how you...
I'm listening to you, I just want to get
that's okay, but I don't know how you quantify that. So usually when I'm doing it in practice, I say about how many pads or tampons and whether they're passing clots.
Okay, that's good. You are talking about history. Now let's define it. But let's finish with the definition first,
Mm-hmm.
and then we go into details about the history. So can we just go through the definition again?
Yeah, so I think it's just a heavy periods beyond what's expected of normal menstruation.
When you say menorrhagia, it's actually no. It's regular. You need to put that word regular to differentiate it from something like metromenorrhagia, which is abnormal, heavy bleeding, but not regular.
Okay.
Which we now talk about maybe abnormal uterine bleeding.
Yeah.
So with menorrhagia, it is actually regular.
Mm-hmm.
So it will occur between 24 and 35 days of the cycle.
Mm-hmm.
So you differentiate that from abnormal heavy bleeding. So this one is regular heavy bleeding.
Yeah.
So having defined it, then we talk about the history. So let me just get this up first so that I can face you while you are talking, so that it doesn't seem I'm not listening to you. Let's put something stop for maybe we can come. Here we go. Yes. So this is the one that I was talking about there from the website, and it's very good because they are case scenario. Well, then we can then discuss them in details.
Yeah.
Okay. So you have defined. We try to define it, and we say that you want to. Why is it important? Why is
So it's really common,
right?
and there are some serious underlying conditions that can cause heavy bleeding.
Mm-hmm.
But I think the main thing is that lots of women present with it, so it's something that comes up a lot and needs management sort of through women's lifetime when they're menstruating.
Mm-hmm. So 1 in 20 women aged between 30 and 49 consult their GP with heavy menstrual period. Once referred to gynecology, surgical intervention is highly likely. 1 in 5 women in UK will have hysterectomy before age 60, and that's true. In at least half of those who undergo hysterectomy, heavy menstrual period is the main presenting problem, so which you rightly said. About half of the women who have hysterectomy for heavy bleeding have a normal uterus removed. Only 15% of women receive medical therapy before referral to specialists, which will come up soon. Because I noticed that some, especially the locums, when they say patient comes in with heavy period, scan, refer to gynecologist, but there's a lot more we can do as general practitioner in primary care. And the NICE guidelines also said when you are supposed to. So we'll come to that later. So, but only 58% of women receive medical therapy before referral to a specialist. So when next you see a patient with heavy menstrual period, after this tutorial, you won't be one of those
It's referring
straight to gynecology. So NICE issued new guidelines in 2007. Okay, so we'll talk about why it is important. So you have defined this. So it's heavy menstrual period, as excessive menstrual blood loss, which interfere with woman physical and thought, but to add that it's regular as well. It is regular and within 24 to 35 days of the cycle. Okay. So what are the causes?
So I suppose it's how you put it into the causes, so you can do it into kind of location in terms of the reproductive system, or whether you can do it in benign and malignant.
Okay, so how do you want to do it?
So I think and there's just systemic things as well, like hypothyroidism and things.
So what does hypothyroidism cause?
Menorrhagia, as in if you have hypothyroidism.
When you have hypo, it causes menorrhagia, but when you have hyper, then it's oligo.
Right.
So it's the other way around.
Yeah.
Okay.
I suppose the most common is just dysfunctional uterine bleeding, and there's not any sort of obvious underlying.
So what's the definition of dysfunctional uterine bleeding, or what is called abdominal uterine bleeding now? What is that? What is the definition?
I thought it was physiological, that people can just get heavy periods, but that there's no sort of underlying cause found.
In the pelvis.
Yeah,
there's no underlying cause in the pelvis, but there is underlying cause. Like if you have the mono, like PCO for example, that would be an underlying cause, but you can't find any cause in the pelvis. But it doesn't mean that there's no underlying cause. There is, but not in the pelvis. So that's the difference, right? So you say you were going to. So if we go to benign and malignancy and systemic causes. So if we start with that, so go.
Yeah. So benign, quite commonly in malignant fibroids, might cause heavy bleeding. And then other kind of things within the uterus, so endometriosis or adenomyosis.
So what's the difference between endometriosis and adenomyosis?
I think adenomyosis is to do with the muscle, is that right? I'm not 100% sure.
Okay.
Endometriosis can affect anywhere where the endometrium grows where it shouldn't be growing, so it can affect the bowel and various other organs.
So adenomyosis is when you have the endometrial tissue in the muscle of the uterus. Adenomyosis, endometriosis. So what is under benign before we move on to malignancy?
So sometimes it can be things sort of from uterus or on the cervix, like polyps.
Okay, polyps, endometrial polyps, yes.
I think that's...
So before we move on to malignancy, when you were talking about benign, you said uterine fibroids, which is one of the commonest, that's true. So why is uterine fibroids causing menorrhagia? Why?
So I suppose it depends where the fibroids are. I'm not actually sure what the pathophysiology is.
What happens to a woman when they have fibroid? What happens to their womb?
It gets bigger.
So when they get bigger, what is feeding them to make the fibroids bigger?
Because they get bigger blood supply.
Blood supply, so because you have the extension of the surface of the uterine cavity, and therefore the increased vascularity. So that makes them to bleed more. So that's the way fibroid causes that. What about polyps? You say polyps as well, which is correct, but why are they causing heavy bleeding when they have endometrial polyp?
Is that a similar reason because of the increased vascularity?
No, vascularity this time around is because of it can look like endometrial hyperplasia.
Okay.
You know what that is? Endometrial hyperplasia?
There's growth of cells kind of over what you'd expect.
It's just that there's more thickening of the uterine cavity, and if it's not checked, sometimes it can lead to endometrial cancer.
Okay.
So the polyp can enlarge the endometrial cavity, and that will give the same sort of effect, and then you can have bleeding. So what else?
We sort of said dysfunctional uterine bleeding, but
Okay.
Yeah, I'm not sure again what. So
What
you
else is
said
there?
about PCOS and
Yes, we talk about PCOS, that would be under dysfunctional uterine bleeding, because you can't really see anything. It's because of anovulation, isn't it?
Yeah.
Okay, so what other thing can cause, before we go to malignancy, what other thing can cause menorrhagia? So if the patient has underlying clotting disorder, will that cause problem? Will they cause bleeding?
Yeah, it might cause it if they have like if they I don't know, because can they get it if you're on warfarin and things, or
anticoagulant that causes it. And there's some young children as well that they just bleed and bleed and bleed. Something you have to think about screening them for coagulation disorders, especially young girls, because sometimes we know when they present to us, we say, oh, maybe because their their ovaries are not mature, that's why. But
Yeah.
if it's so heavy that their HB is really very low, then maybe to screen them for bleeding disorders. I've seen quite some young girls who have a problem with maybe one deficiency or what they call the what's the name of this deficiency when you have a deficiency? Anyway, I can't remember, but these young people, when they have that, you want to make sure that they don't have any deficiency of the blood disorder that
Yeah.
lead them to.
So like haemophilia, do you mean? Or-
No, not hemophilia, because usually girls don't suffer from hemophilia,
Yeah.
but deficiency of Trubin 2, so we'll check it later.
Okay.
Trubin 2 deficiency. We'll check it. We'll check it at the end and see. So just query that to be
Yeah.
checked. It's not hemophilia, because usually women don't suffer from hemophilia. But when you find these women who keep on having recurrent abortion also, you screen them for blood disorder. That's what I'm trying to remember.
Mhm.
So we'll check that later. So we talked about the benign one. What about malignant causes?
There's sort of cancer, gynecological cancers, so endometrial cancer or ovarian cancer or cervical cancer.
Mm-hmm. So what are the risk factors for people with endometrial cancer? So you are right, so I'll put that up for you. Yeah.
So endometrial cancer, I know that some things are protective, aren't they? Because if you take the combined pill, it's protective against endometrial cancer.
Well, I'm talking about the risk factor.
Yeah.
You're talking about protective. I'm saying what's the risk factor.
But I think, is smoking a risk factor? No. I think I'm trying to remember, because I know that with like breast and cervical, it's things like your parity and having early menarche and late menopause. I don't know if that's the same for
Late menopause is one of the risk factors, yes.
Yeah.
So if you see a patient who is 56 or 58 and is still having a regular period, he should be investigated.
Okay.
Even if you say, oh, my mom has late menopause as well, and say, oh, but how old? I don't know, but she has late menopause. 58, 59, having regular period, you want to assess to make sure there's no functioning ovarian 6, or that is producing estrogen that is still making her to have regular periods. So yes, so it's important that you check late menopause and also obesity and hypertension. If you have those combination, obesity, late menopause, and hypertension, they can be risk factor to endometrial cancer. So you talk about the causes, cervical and ovarian. Okay, so shall we go to case scenario? Yes. So case 1, this is a 28-year-old lady, comes to see you as she's tired of having heavy periods. She says she has always had heavy and painful periods for a long time, but it's finally at the end of her tether with them. What do you do first?
So take a history and kind of find out about her. Is she having regular periods? Define how heavy they are, and if they've been heavy from the time when she started her periods, if it's changed at all or become much worse. And then ask sort of the questions around risk factors and kind of do sexual health screening as well. And then after you've kind of taken the history and just checking for if she's got any other past medical history.
What past medical history are you interested in?
So I suppose looking if she's a diabetic or has thyroid problems or
what sort of thyroid problem?
So if she's hypo or hyperthyroid, like we said earlier.
Okay, but you say it's heavy period, isn't it? So
yeah.
Last time we
so
said
hypothyroid, yeah.
Good. Okay.
And then sort of going on to examining her, sort of just doing general checks, checking her blood pressure, pulse, doing a abdominal examination, And I don't know at this point whether you'd be thinking about doing a pelvic examination. Just
When would you want to do a pelvic examination for this patient who has this type of presentation? When will you do a pelvic examination?
Yeah, I suppose because she's had it for a while.
I'm not saying why, I say when.
Yeah,
This scenario, will you do a pelvic examination or not?
probably not.
Why not?
Because she's always had heavy periods, so it's not a new problem. But I suppose you could maybe check if she had a polyp or something, you could check.
Because it's painful, isn't it? It's heavy and painful, not just heavy, but it's painful as well.
Yeah.
So you want to examine to make sure there's no other thing.
Yeah, check there's not another infection or anything.
Okay, so let's see what you missed out in the history. So you talk about the frequency of bleeding, the tampon, the details of the, so that you can quantify, because you can't really measure, as you said at the beginning when we started, at 18 mils, if it's more than 18 mils, but when clinically you can't say, oh, bring your bar, let me go and put it in the container, measure as 18, but at least how frequent is it? Is it flooding? There are some patients that will come in and they say that, you know what, I have to wake up at night to change my bed sheet because of clothes. Sometimes when I have my period, I don't want to go to work because I work with my colleagues in the office, and when I get up, you know, my skirt is soaked with blood, so usually I can, then you just have sense of how heavy it is without actually saying, oh, it's 18 minutes or so. And how many days is the bleeding? Is it throughout? Is it throughout the menstrual cycle, or just during the menstrual flow? Is it just for a few days, or if her cycle is 4 days in a regular cycle of 28 days, is it the whole 4 days or just 2 or 1 day? Pelvic pain. She said they were painful, so you really want to define or specify when is this pelvic pain. It's only when she's menstruating. Is it associated with intermenstrual bleeding? Is there postcoital bleeding? Is there pain during sex? Is there any discharge? Issues, how many children does she have? You talk about STI, so how many partners in the last maybe 3 or 6 months? She's 28, her scenario is 28, so when was the last smears? Because she's eligible for smears from 25 years. So she does not smoke. There's no family history of any sickness. So you didn't mention the family. So you miss out some of those history salient points. So in as much as asking for number of pad, how many time does she change, how frequent, you want to know any clothes. Is it associated with clothes? Is it flooding? Just to give you, does she have to take time off work? You have to. So that's the history. So will you examine this patient? We have discussed that already, didn't we? It's an abdominal examination, yes, pelvic examination plus or minus depending, because if it's painful, when you say yes, it's painful, or if there's postcoital bleeding or intermenstrual bleeding, then you know that it's associated with other things, so you want to actually do a pelvic examination. But if there's no history of STI, you're not really worried at all, according to the NICE guidelines, then you don't have to do that. So this patient examination was, abdomen was soft and no masses felt, right? So let's relate it to NICE guidelines. Abdominal examination is recommended for patients with abdominal pain, bloating, constipation, back pain, and urinary symptoms. Yeah. So as we discussed along, we are doing case scenarios. So instead of just opening to NICE guidelines and just reading it, we are trying to make it more practical to our day-to-day experience as GP, rather than just opening to NICE guideline without relating. So it makes more sense when you see the next patient of menorrhagia. Right. So what investigation will you do for this patient? We're taking a history, we are happy with our history. So what investigation will you do for this patient?
So you definitely want to be doing a full blood count and possibly a ferritin with it to check that she's not anemic, if she's had years of heavy bleeding.
Why do you want to do ferritin?
Because it's likely that will be an iron deficiency anemia if she's bleeding.
Right. So if you do a full blood count, I want to give you an indication.
So as in the full blood count will show a microcytic anemia, but when in my practice I've always been asked to do a ferritin because then you can start them on iron tablets if the iron's low.
So what did NICE guidelines say about doing thyroid function tests and ferritin in patients with menorrhagia?
Well, I assume that you do thyroid function.
Okay. Right, so let's see. What investigation will you request? Full blood count indicated all women with heavy menstrual bleeding.
Okay.
Coagulation only indicated if heavy bleeding since menarche. Other symptoms like the abnormality, the blood disorder that I was talking about when there's deficiency. I can't remember what it is that we're going to check up. So only indicated if heavy bleeding since menarche, other symptoms or family history of any blood disorders, then you do coagulation screen. So you don't do coagulation screen for every patient that present with heavy menstrual period. But depending on when you're taking the history, if you suspect that, like I was telling you at the beginning, that some young children, they may have very heavy bleeding, that you should think about blood disorders instead of just saying, oh, because their ovaries are not matured or the pituitary are not matured. So thyroid function and ferritin not required unless clinically indicated. It's the same thing with when you are investigating for self-fertility. The FRCOG green top that I told you about, your result that you can refer to, they say that thyroid function test is not routinely indicated for investigation with fertility. You walk up, except if it's indicated. So when you are taking your history and the woman say, oh, well, my neck is swollen, or I always feel hot when people are feeling cold or something. So in your history, if there's something suggestive of abnormal thyroid function, then you can do TFT, but it's not. And TFT and ferritin not require or less clinically indicated. So like you said that if the patient is really very anemic, then if HB is very low, then you know that, oh well, it's not just enough to replace the hemoglobin, but the iron storage, the ferritin, then you want to. But if the heavy period, then you are right to do. So that's what the NICE guideline is trying to say. You don't just routinely jump to, oh, this patient has heavy period, okay, let me do ferritin level. So if you examine the patient and you find that, well, because sometimes women, the percentage of women who say they have heavy period, that actually when they investigate and use 80 mL as standard definition, you know how many patients that present to you to say they have heavy period, that actually when you do that, the research have shown a percentage of them actually fulfill that criteria. Do you know the percentage?
I bet it's quite low.
Very, very low, very, very low. So that's why we are saying that don't just automatically do ferritin with this case. But if you see a patient who is very, very, very pale, and you feel that, oh, this one's really, clinically I could see that it's anemic. So you want to do the ferritin because you want to replace the storage as well as bringing the HB to normal. So that's what that is talking about. So you can do ferritin because I know you responded by saying, oh, but when we do food, we always say to do ferritin. But this case that we are discussing, knowing that less than 20% of those who will present with menorrhagia actually fulfill the criteria, it will be a waste of resources to be just each time you have this patient, you just do ferritin. But of course, clinically, if you feel that yes, this is low, you want to do the ferritin as well, because then you want to replace the storage depletion as well.
Okay.
Does that make sense? So
Yeah.
I'm not confusing. Does that make sense? Or am I confusing you? Because when I mention you say, oh, but when we do full blood, what is the ferritin?
It's very nice saying that. I just wonder whether if someone came in and you check. So I did the other day where I checked someone's full blood count, and now they've got myxotic anemia, and now I have to try and add on the ferritin. But if I just done it at the time, then it would have, like, it adds an extra step, doesn't it? If someone comes back and maybe clinically doesn't look anemic. So now I'm thinking, do I start doing ferritins when if I'm checking for anemia in someone who's got, I'm expecting the blood loss to be coming from heavy periods, then in order to guide your management, you'd be doing ferritin in anybody you're going to check for anemia in.
Well, that's what I was saying, that it depends on your clinical acumen.
Yeah.
Because there are some patients that you will see that you just look at their, their lip, you look at their fingernail, you check their conjunctiva, although it's not very accurate, you just find that. Or if a patient is saying that, look, I'm breathless, I'm having palpitation, and actually having the symptoms that they're symptomatic, then doing ferritin at that stage there's no problem, because then you are wasting time, as you rightly said. But there are some occasions where I think what NICE guidelines is saying about not to request it or except clinically indicated. It's like if you see a patient is symptomatic and from your history you say, oh, I'm flooding, I have clots, I can't go to work for the first 3 days of my period, then that's clinically indicated, isn't it? But you see some people, they say, oh, you know what, I'm having heavy period and all that. Then you take the history, there's no clotting, there's no flooding, there's no sign of you know what I mean? So in that case, is it clinically indicated? When you do a full block and you find that it's even higher than yours. And so, okay. So I think those are the elements that they're talking about. So I think there's a room for that. But it's not a blanket thing, so you just have to clarify that when you say it. So what management options will you offer?
So I suppose you want to know whether she's trying to get pregnant, as in she wants to contraception as well as if she wants to try and manage it with contraception, or if she's trying to get pregnant would change what you're doing, because obviously you've got hormonal methods of managing. And I think the NICE guideline is first line is Mirena or an IUS.
Okay, so what do you know about Mirena?
So I know there's Mirena, and then I think it's called the J. There's the 5-year one and the 3-year one.
Okay.
And they're progesterone systems that are.
So the 3-year one, what is it called?
I think it's JDAS or something.
JDAS. Good. Okay.
And they are used to try and. Obviously it's contraception, but it's also to try and reduce heavy periods and painful periods.
So how does it work?
So it's localized progesterone. So progesterone on the womb, sort of, I think it increases cervical mucus and also does it thin the lining? I can't remember exactly what progesterone, but it basically produces progesterone so that you're preventing implantation.
So if I give you this a patient, and you just I'm one of these patients that we discussed.
Yeah.
I'm having period, and you say, oh, I think I like that idea of this Mirena. So how does it work? I have this model here. So
so you'd say, so it's a small device that we insert into the womb. Before you have it, you have to have some screening to check that, to have swabs done to check for infection beforehand.
So what sort of swab do I have to do?
So just you can do a self swab to check for infection.
But why can't doctor do it for me? I don't really like touching. So why?
You can book in one of the nurses to get the swabs done.
No, but I heard before as well that it's good for the patient to do it herself, but I'm just wondering why.
So actually recent evidence suggests that the pickup rate of picking up infections, particularly sexual infections, is better if people do self-swabs.
Which infection?
Things like chlamydia and gonorrhea.
Oh, okay, that's true.
Yeah.
So usually when they say swab, they can pick up the urethra area, and the vaginal wall, rather than just doing the endocervical. So that's yeah.
So after we've gone through that, then you'd book in one doctor so you can do.
Well, how does it work? Because you say they put it here. When they put it here, so what happens here? So how does it work?
So they use an introducer and put the device so it sits just above the neck of the womb in the uterus, and it basically produces a small amount of progesterone, which is a hormone that then is effective in stopping pregnancy and stopping implantation.
Well, how does it stop it?
So I think it's to do with it changes the cervical mucus and it also changes the lining of the womb.
Okay, so it's made the lining of the womb to be thin.
Yeah.
And also it prevents ovulation. So 3.
Okay.
So at this level, at the cavity endometrial level, and then prevents ovulation, so you don't have the release of egg. Okay, so that's the way it works. So fine, so you can use that, and by doing that, so we talk about mechanism of action, so uterine fibroids as well as endometrial polyp that increases the vascularity and therefore enlarge the endometrial cavity. Because of that, they then tend to bleed more. So from your mechanism of action that you have said that the IUS will sort of thin the lining of the womb, so therefore there's no bleeding. So you need to inform them that sometimes you will not bleed, but it doesn't mean after a year you might not have your period, but it doesn't mean that you are menopausal, because sometimes patients they adhere to their method that you suggested to them. If you tell them what the possible side effects and how to manage it if it comes. So if you just say with one of them, say, okay, I will do this, and without telling them what will happen, they get so stressed when they don't see their period. So, oh my goodness, so am I menopausal? I'm only 28 and I'm not seeing my period again. The doctor didn't tell me that. So if you tell them beforehand at the time of your consultation, then they know that this could happen. Yes?
Yeah.
So that's one.
And it's really something that the takeout rate is really high of Mirena, like up to 60% of people get it removed within 5 years.
And why do you think that is the case?
I think it's probably because of the irregular bleeding that happens with it, or that it can.
And how can you manage that during your consultations? Tomorrow, if you see a patient in your surgery, so how will you manage that expectation so that they don't remove them before?
Yeah. So usually I say to people, when you initially have it in, you might have sort of in the first sort of 3 to 6 months, you could have some slightly irregular bleeding, and initially when it's put in it can cause pain, but then you've got to think about for 5 years you've got the benefit of most women, I think it's, I can't remember the percentages, but most women either get complete normal periods or they can get very light irregular periods. But I didn't know what in your practice what the best way to explain that is.
Yes, because most of the time the patients come in and say, oh no, when I got put it in, they didn't tell me that. They said I may have slight bleeding for 3 to 6 months and that's it. So I try to tell them that, look, if there are some women who don't have actually heavy period, but because their friends are using, or they just want to use it for contraception, and their periods are not heavy before. So you have to say to them that, look, this device, although it's going to make your period to be lighter, but actually it's going to make your period to be heavier in the first 3 to 6 months. Not slight bleeding, as you said, because if you say slight bleeding, then they come in and they say, you know what, my period before I put this in was not as heavy as this, and they said that it's going to make my period to be lighter. And usually it's after the first 6 months that you notice the effect. So if by 3 months they are saying that I was not told that the periods are going to be this heavy, I was just told that slight bleeding for 3 to 6 months, but this one's heavier than what. So you need to tell them that actually it may be heavier than your normal period before, and it can go up to 7 to 10 days. But after 6 months, you start, if it's going to work for you, then you find that the period will be becoming lighter, and after a year you might not see your period. But having said that, it's not all the women that may not see their period at the end of 1 year. Some people, some women, they may not even notice any change at all. It will just be the same, and they continue to have their period. So I don't know which category you belong to, but there's some people, they put it in before 3 to 6 months, they don't see their period at all. So I don't know where you are going. So if you give them that sort of scenario, then they have an open mind, and then they don't come in and say, oh well, I was so that the first 3 to 6 months is going to be slight bleeding, but now actually it's heavier than my period. So you prepare their mind and you manage it at that point, and you say, and actually if you are one of those that we have heavy bleeding, despite this, we do have treatment. We have treatment also. So you sort of preempt them, so they know that if they have problem, they can always come back that, oh, I was told.
Yeah.
Was that what you were asking?
Yeah.
Question? Okay. So we say, what investigation will you request? We've done that to visit it. So it was a management option. So you talked about IUS, so we talked about this pelvic exam needed for, so we were talking about the swabs that you were talking about, how you take that. So the guideline says that before you put the coil in, you must check for chlamydia and gonorrhea, and self-swab is better than doing endoscopic cervical swab. So you talk about it. So patients, as you rightly said, if they want a baby or they don't want a baby, therefore they can use that contraception if fertility is not an issue. So it can act as contraceptive, aside if a regular bleeding, hormone-related problem that we're talking about. So another thing that you can, while we are there, because one of your aim for this tutorial is that overall keen to learn general women's hair in more details, so anything suits. So I will just be going along as we go along to be mentioning things in women health. So if you talk about IUS, you can use the IUS as the second part of HRT. So if a woman is using maybe estrogen only HRT, and the patient has, she said, oh well, I just want estrogen only, I'm only on estrogen only, so, and I have this, I want contraception as well, because HRT is non-contraceptive, isn't it? So you can then use IUS as the second part, as the progesterone part of the HRT. So the woman has whether oral HRT, and then to prevent the endometrial lining, the IUS can then be used. But when you use the IUS as the second part of HRT, instead of 5 years, then it's for only 4 years. So you have to remember to tell the patient that, excuse me, this is usually for 5 years if you are using it for contraception, but we are using it for a different indication here to protect your lining of your womb, so that it doesn't. What happens if they take only estrogen without progesterone?
They're at high risk of cancers, BT, stroke, cardiac risks.
Good. So that's why. So
But you know because in the guideline it says about you can use IUS for 7 years in perimenopause, people who are between 45 and 50.
So if you are fitting the IUS in patient over 45,
Yeah.
so instead of 5 years, it's then 7 years.
Yeah, but that's not true if they're on HRT. So it's always 4 years for HRT.
For HR, because it's different indication then.
Yeah.
Yes. So if you are using it as the second part of HRT, it's always 4 years, even though if they are more than 45. Yeah.
Yeah. And I just wondered practically how that works if you put the IUS in when they're 46, and then you kind of get them to 52. When you take it out again, what do you tell them about their fertility? As in, what do you tell them about?
Okay, very good. So if you need to know when the patient became menopausal. So if the patient became menopausal before before 50 years. So maybe the woman became menopausal at 48 years, for example. It means that when she has to use contraception for another 2 years before we stop.
Okay.
So, but if the patient is 50 years before she became menopausal, then she has to use contraceptive for 1 year, if that's the question you are trying to ask.
But if, for example, she had the IUS in and she was amenorrheic with the IUS, she wouldn't know when she's menopausal. Do you know what I mean? Like if you put it in when she was perimenopausal and she was getting really bad bleeding, and she said, I want contraception and I want the IUS, and so you said, fine, we'll put it in at 48.
So we
she's
put
still
in at
having
48, yes?
regular periods. And then at 52 she says, I'm being amenorrheic with the IUS, can I have it out, will I be fertile? Then you wouldn't be able to tell her.
No, we won't be able to tell her, but you can then do FSH then.
Oh, okay, fine, yeah.
You can just do FSH
Just do it
and see.
Biochemically, okay.
Yes.
Yeah.
Although usually if that's not the scenario you painted, if patients are more than 48, you don't need FSH to confirm a menopausal status, but it's slightly different from the scenario that you painted.
Yeah.
Good.
Yeah.
Does that answer your question?
Yeah, yeah.
Okay. Right, so we talked about pharmacological treatment, we talked about side effects, then we debated to other functions or medication for using IUS and gynae. Okay. So first line according to the guideline is IUS. Then second line is tranexamic acid, mefenamic acid, or a COC. So for example, if you think you're going to investigate the patient while you are investigating, you can then use tranexamic acid or any of those. So, but then you should stop tranexamic acid or mefenamic acid after 3 cycles if no improvement, because I see sometimes patients are put on repeat prescription for tranexamic acid for only God knows how long. So maybe something, an audit you can do in your practice and see patients on tranexamic acid. If they're on tranexamic acid, are they on repeat? And if they're on repeat, for how long have they been on repeat? And you could just change that. And so that's something you can do.
But what if they're saying it does help? What if they have menorrhagia and then they're saying it?
If they say if no improvement.
Yeah.
So if
they can be on repeat.
So if it's helping, yes, but if it's not helping after 3 months, you should stop it if no improvement. But if it's improvement, yes. So when you are doing your audit, for example, if the patient says no improvement, but you say, well, in the world of nothing, let me continue. So such patients, so you can look and see, was it within 3 months? It's more than 3 months, is it because it's helping or it's just
yeah.
So, for example, if the patient has menorrhagia as well as dysmenorrhea, so instead of using tranexamic acid, then you can use mefenamic acid, because mefenamic acid will help with the pain as well as the heavy bleeding. Good. So that's our case 2. So third, you can use multisteron or injectable progestogen, like you can use Depo. And how does it work? It prevents proliferation of the endometrium. So because we said before that hyperplasia causes vascularity, therefore they bleed. You can use norelintide 50 milligrams daily from the 5 to 26 or the menstrual cycle. So you can use, or you can use the Depo-Provera or norelintide 50 milligrams from the 5 to 6. Usually you have to tell them about irregular bleeding and also bone density loss. Previously it was said that once if the patient is 45, don't give, but then extended it to 50. So if a patient is having depo, there's a patient who is on depo-provera, she has endometriosis, so it's helping her with her pain. So even when she was 50, she still wanted to continue with a depo-provera, but now she can continue because of bone density. And once you are 50 and you are perimenopausal, or you are actually menopausal, and you are taking something that has something that will reduce your bone density, then it's not useful. So although it's helping the other side, you have to reassure the patient that you know what, it's no more useful for this purpose.
I think what I struggle with sometimes is with these young girls who potentially don't want to be having IUS and are having flooding or having something where you're trying to find out what's going on, about how you make the decision between northisterone and going for the tranexamic acid, mefenamic acid, because different GPs have told me different things about saying give northisterone or give, you know, which one you do and how you decide.
So first of all, I think this is number 3. The northisterone is number 3.
Yeah. So
and if you keep on having high dose of northisterone, although it's progesterone only, there could be risk of clots as well, because it's a very high dose and you are not using it like contraception in this case. So it's not the first line. The first line, it depends. One thing I found that, and there's a research as well that showed that the people acceptability of a method depends on the experience of the person who is actually counseling the patient. What I noticed is that people counsel patients in line with what they are comfortable with. So for example, if you are not a fitter, you are not going to counsel a patient that, you know, actually the first line of thing is IUS. You say, oh, okay, we can give you a pill, we can give you mefenamic acid. So because when you present it to them and they know that you know what you are talking about, they tend to. But when people say, oh no, the patient doesn't want to do it, it's not really because of the patient, but it's part of inexperience of the person who is talking to the patient. Because I see cases that people will say, oh, the patient doesn't want, then they can say, no, it's because when I ask questions, they couldn't answer my questions, and also when they were talking to me, it seems as if they don't really know what they are talking about. So you tend to see locum just saying, oh, let's give you a depo-provera, let's give you oral contraceptive pill, even if the patient says, no, actually I don't want to take oral contraceptive pill because I don't want my mom to know that I'm taking the pill. But that's what they are comfortable with. So I think the research has proved that it depends on the experience of the person who is counseling, because you find that when you see other people, they say, okay, yes, I will have it. Because some people will pain, or some GP will tell patient, oh, because you are younger, the neck of your womb is not big enough for you, so you will have pain. But that's not true, because you can actually give gel, and some of these girls, you know, their cervix is not as tiny as you think, and when you give them this gel, it opens up the cervical also, and you can actually fit it in. So so it depends on it. Does that make sense?
Yeah.
Okay. Right. So that's case 2. Right. Do you want a break or do you want us to continue?
No, I'm okay. You're
okay. I'm okay. Yeah. Okay. So case 2, still on menorrhagia. A 30-year-old woman had the Mirena oil put in 1 month ago for heavy menstrual bleeding. Before this, she was on COC, which did not control her period. So unfortunately, she presented today because the coil was on a spell a few days ago. She said this was because her bleeding was so heavy. She's now on her 4th day of her period and suffering mild discomfort. She goes through 10 pass per day and has passed a few small clothes. She said she had to take 2 days off work because she had to change her pad so often. Was fearful of accident and had pain. I was telling you about assessing the severity last time. So she wants something done about it today. So she wants something done about her period, and she's adamant that she does not want another Mirena. He said, as she feels it won't work. What other treatment could you offer her?
So obviously you just need to check she's hemodynamically okay if she's bleeding that much. And then maybe also just check a full blood count if she's having that bad flooding. It sounds like a lot of bleeding.
And then ferritin.
Yeah. And then I suppose it's the options we were just discussing. So because the IUS has not worked, then it's going on to the tranexamic acid, mefenamic acid, and potentially if that's not working, then try northistrone next. Acute thing. But it's just whether you need to refer her because if medical management is not working.
So at what point will you refer her?
I suppose we could try those initial things on this cycle and then, like you said, refer after, review at 3 cycles in whether that's working, or kind of after this cycle bring her back. And then if it's still not helping, then refer her.
Okay, so let's go on. So management option will include tranexamic acid. So how does tranexamic acid work?
It's something to do with the clotting, isn't it? But it basically helps it not, because you use it in like big GI bleeds and things. So I don't actually know how. Is it something inhibits something?
So it stabilizes the blood vessels. So put that down. That's something you need to check and see the mechanism of action. So mefenamic acid, COC, oral progesterone, like we talked about. So injected and implanted progesterone, and consider referral to a specialist. So you try your IUS, you try your tranexamic acid, COC, and if they fails, then you can consider referral, but not just bleeding and then next thing is referral. Yeah. So she now decided she does not want any further hormonal treatments. When she was on the pill, she noticed severe changes in her mood and breast tenderness. After discussion of all options, you both agreed to her tranexamic acid. So you also organized a pelvic ultrasound. She tried tranexamic acid for 3 months. She came back 3 months later and said that tranexamic acid has made very little difference in her periods. Her ultrasound was normal. She has been discussing matters with her mother, who has a hysterectomy in her 30s. She says she would like to be referred for a hysterectomy. So what would you do?
So I suppose it's reassuring her ultrasound is normal, but I think it's difficult, isn't it? Because I think you would definitely refer her at this point because medical management hasn't worked. But I would say I'm not a specialist in what surgical management they can offer you, so it would have to be for the specialists to decide what they want to do.
Okay.
Because I don't know whether they would go straight for a hysterectomy. There's probably other things they can do before that.
It depends on what the patient wants. For example, if the patient is still interested in fertility, so there are other options that you want to do conservative surgery, like maybe depending on the maybe ablation or here they said that the ultrasound was normal, isn't it?
Yeah.
So if it was not normal, then you think about that things you want to do.
Yeah.
Otherwise, depends on the patient's preference. But now she's asking for hysterectomy, and she knows what she wants. Yeah.
Yeah.
So. Also, the patient is recommended that the patient. So yes. So however, according to field management, it is recommended that the patient is referred according to NICE guidelines. Yes. Right. So imaging is recommended in the form of ultrasound if pharmaceutical treatments fail. So it's once the patient have menorrhagia, first thing is not to do ultrasound, but ultrasound is recommended if pharmaceutical treatment has failed. VA examination reveal a pelvic mass of unknown origin, so you're not sure whether it's coming from the uterine or ovarian, so you want to do a VA. Or if the uterus is palpable abdominally, at least if it's palpable abdominally, how many weeks would that be in gestational sense?
16?
12. 12. Well, so you can calculate this 12. So you want to do that. So then nice guideline, re-endometrial ablation. So we were asking that, okay, you don't know the surgical management that we do. So these are some of the surgical management. So endometrial ablation should be considered in women where bleeding has severe impact on quality of life, and they do not want to conceive in vitro. So because if you do ablation, then you may have uterine perforation during pregnancy because you thin the lining of the womb. So if the baby is implanting and the pregnancy is getting bigger, you may have ruptured uterus. So it shouldn't be for those who are still looking for baby.
Yeah.
So with heavy bleeding, who have a normal uterus, with small uterine fibroid, if it's less than 3 centimeters. So if they have uterine fibroid less than 3 centimeters, then ablation then is indicated. Preferably hysterectomy alone when the uterus is no bigger than 10 and suffer from heavy miscarriage. So preferably you can do hysterectomy alone when the uterus is no bigger than 10 years. Yes, women must be advised to avoid subsequent pregnancy and they need to use effective contraception, as I said, because of their uterine ablation. Yeah? So,
would you be if you did get pregnant, would you be recommended to have a as in, would you just continue the pregnancy and see if it's an issue, or would you be recommended to have a termination if you have ablation?
The patient, no, they will tell, if the patient have ablation, they will usually tell them to have contraception, effective contraception, because you see, it was said that when they have ablation, they should use contraception because of risk of perforation. So you wouldn't allow them to get.
But if they accidentally got pregnant, if they were put on the pill and they didn't take it.
No, but you can't do ablation and just say, oh, pill alone or something. So you have to really warn them.
Yeah.
You have to warn them and say, look, this ablation, if you get pregnant, that I think that will make them to be, and if you think that they are the type that will not take the pill, then stick them with something. This is what I was talking about assessing patients and not just saying that, oh, even if the patient said, oh, I want the pill, if you do explain to them the reason why, you can't tell the patient that, oh, you must have the pill or you must have this, but effective contraception consultation is to tell the patient that these are the options in your scenario. If you do this, this is it. If you do this, this is it. Then you make the patient, you help the patient to make the option. But if you just, oh, the patient said he wants to use it, but does he know if he gets pregnant, the impact? There's no, it's only a mad woman that says, yes, I want to get pregnant so that I can perforate my uterus.
Yeah.
You know what? If it's going to be an issue that you will forget your pill, there are other options that you don't have to remember to take your pill, A, B, C, D, something. Then the patient will say, oh, I didn't know that. So it's effective counseling of contraception when you are doing this sort of thing. You can't just say, okay, if that's patient's choice, yes, but you are supposed to guide them and help them to make healthy and safe choices as well. Can we move on?
Yeah.
Okay, so the abdominal and pelvic examination principle for infection examination, this is case, we'll finish with case, yes, so this is case 3. So 41-year-old lady come to see you with a 12-month history of increasing heavy and painful periods, significantly affecting her quality of life, no dysuria, no frequency or incontinence. Last period was 2 weeks ago, and her ketamania is 7/28. You know what I mean by ketamania? Okay. Ketamania means that the menstrual cycle that the patient bleeds for 7 days is at least it's not an English word. When you are doing your gynae history, you write K. That K stands for ketamania. That is what is his cycle length, and how many days does the patient menstruate. So 7/28. So ketamania is 7/28. So if you see K 7/28, it's saying that the patient has regular period every 28 days and she bleeds for 7 days.
Yeah.
So that's what ketamania means. So 2 children, last year was normal, no past medical history, but grandmother had 5. So what would you do?
So
Okay.
and just do a pelvic examination because this is new head heavy bleeding since the onset of menarche. So yeah, so you do an abdominal, pelvic, and do swabs.
Okay, so when you do that, you suspect that she has fibro, but you're not quite sure because you don't know whether it's actually a central or it's coming from the adnexal. Yeah, or something sinister. So, what will you do next?
Yeah, so like we said before, you do a full blood count and anybody's having heavy bleeding.
Good. Why should you be doing pregnancy tests and everyone having heavy bleeding?
I suppose to rule out there's not anything happening within the pregnancy setting. So if
Like what?
If they had a distended abdomen and then they had heavy bleeding, you'd be concerned, in early pregnancy about miscarriage and ectopic, and in late pregnancy.
If they have ectopic, will they bleed heavily?
So they don't always bleed heavily, but they can bleed.
So when can they bleed heavily? You are right. When can they bleed very heavily?
As in later pregnancy, do you mean?
In an ectopic pregnancy, when can they bleed very heavily? What site? Where would be the site of the ectopic if they bleed heavily?
Yeah.
Where?
I don't know. Is it extrauterine? I don't know whether.
Ectopic is extrauterine.
I don't know, because it wouldn't probably be in the tubes. It wouldn't bleed heavily.
It could be in the tube.
Yeah.
So what's the anatomy of the tube?
So the ectopic can be, well, there's like loads of sites of the ectopic, isn't there? But
on the tube, you just said tube.
Yeah.
So the tube. So where will it be in the tube? Anatomical site in the tube when they will bleed heavily that you're thinking about pregnancy disorder.
I don't know.
Ampulla.
Okay.
The ampullary area. So you have the ischemic region, which is very, very tiny. Then you have the ampulla in the middle, which is wider. So if there's ectopic there and it ruptures there, they will bleed more than in the ischemic one, whereas the junction between the tube and the fundal part of the uterus. Okay? So, first line investigation, if you will do investigation, is ultrasound. Yes? But if ultrasound is more conclusive, then you can then do hysteroscopy. Yeah? So ultrasound confirms uterine fibroid, largest being 3.3 centimeters. So, do you refer this patient?
So I suppose if there's multiple fibroids and she's symptomatic with them, then you would. I suppose before we said under 3 centimeters was considered okay, so over 3 centimeters would refer.
Great. Yes, you will, because women with fibroid that are palpable abdominally. How many weeks did I say gestationally?
You said over 12 weeks. 12
weeks. So women with fibroid that are palpable abdominally, or who have intracavity fibroids, and or whose uterine length as measured at ultrasound or hysteroscopy is greater than 12 centimeters should be offered immediate referral to specialists. Yes, so that's the reason why you will refer this patient. So what management will you offer?
So hers is greater than 3.6 centimeters.
Yeah.
So there's lots of different ways to treat fibroids, isn't there, depending on their size and location. So they can do the uterine artery embolization, or they can do a myomectomy depending on where it is, therefore, in the. But again, I'd say the specialist will decide what they.
So what sites of fibroid do you know?
So there's like subserosal.
What is that?
Beneath the serosa.
Okay.
So I thought that was one of the most common ones.
Which other one do you know?
So you can get like pedunculated fibroids that are less common. When I've seen reports, they often talk about posterior fibroids.
So here.
Yeah. So you can get them like coming into the uterus itself.
So what is that
subserosal.
cause? So the one that's coming to the cavity, what is it called?
Oh, do you know? I thought that was called subserosal.
Sorry?
I thought that was called subserosal.
And so it was we have
submucosal.
this then. Sorry?
It's submucosal.
So it's a submucous fibroid, yes.
Yeah.
And then the one here?
The one that is that subserosal.
No. What is this one? What anatomical position is this one? What's this?
What in the lining in the?
This is the lining which you call endometrium.
Yeah.
So the one there you say is submucous, which is right. So
Yeah.
what of this one? What's this structure in the uterus?
What, the myometrium?
Myometrium, yes, that's the muscle.
Yeah.
Good. So what is it called? If the fibroids are in there, so what's
Are they myometrial fibroids?
intramural?
Intramural.
Okay. And then if this is along the peritoneum, then that's the subserous.
Okay.
That's just hanging there.
Yeah.
So if a woman is pregnant and has fibroid, I say, doctor, while I'm sleeping there, just remove my fibroid for me. So which one will you remove? Having talked about the different sites. So you say, please, doctor, please, when I'm sleeping, just remove that fibroid. Which one will you remove out of these different sites that we're talking about?
So if it's in terms of, so I thought if they were kind of
Sorry, we are jumping into obstetrics because you say you want learn general women's health. So that's why I'm trying to get the aim, your aim, so that at the end of the tutorial you get your aim. So that's why I'm jumping here and there.
So I guess